Good evening, respected professor, my dear students. I welcome you all for this third session of RFD, Rapid Fire Discussion on exam topics. Today we have the second part of the long cases, clinical cases for discussion. Over to professor and students, please.
So last class we managed to see some of the common long cases that are kept in the exam. And today we'll try to finish the rest of the commonly given case scenarios. So I'll straight away go to share my screen with you. Is it visible?
Yes, sir.
Okay. So the case scenario is a 26-year-old lady with a BMI of 38 posted for abdominoplasty and liposuction. So the diagnosis is also given. It is a case of obesity. The questions that can be asked are, what are the patient's complaints? Usually the patient may complain of increasing weight, especially in the abdomen and thighs, wants to get rid of it because of after seeing an advertisement in the TV so that she can look more smarter. Now history taking, what questions you want to ask this patient?
Weight gain over a period.
Weight gain over a period, okay. Then
Other history of endocrine abnormalities, history of hypothyroidism, diabetes.
hypothyroidism, diabetes, okay, good.
Any weight
Any
reduction treatment
26
can
years,
be beneficial.
hypothyroidism is a possibility. Diabetes, because after becoming obese, you could have become a diabetic. But per se, diabetes producing obesity at 26 years is slightly not a very favorable question. Then,
Okay.
He took any medications for weight reduction, sir?
has she taken any medication? Has she attempted any conservative line of treatment? Okay. Then, what
Obesity
category of obesity she belongs to? What class?
3 obese, sir.
Class 3 or
Class 2 obesity.
class 2, class 3? So much of confusion.
Class 2,
What
sir.
is class 1 obesity?
BMI more than 30 is class 1, sir.
30 to 35, class 1, 35 to 40, class 2,
Class
more
2.
than 40, class 3 or morbid obesity. So these are the three things. So she belongs to class 2. What is the common comorbidity that may be associated with class 2 obesity?
Obstructive sleep apnea.
Obstructive sleep apnea. It's a very, very important thing. Every obese patient you should ask that question. Okay? And whether it is familial or acquired, that also can be asked. If the family, entire family, father, mother, siblings, all are obese people, then this may be also genetically motivated. Otherwise, what are the causes of acquired obesity?
Sedentary lifestyle.
Dietary habits. Dietary habit, okay. More intake, less expenditure. That is the most common cause for acquired obesity. Okay, so you must find out the cause of obesity, whether it is environmental, hormonal, or genetic. And if it is acquired, it is mostly due to increased calorie intake and decreased expenditure. What happens to the excess calories consumed? How does this become obese? The patient eats more and does not spend that amount of calories by exercising or by doing physical work. How does that excess intake gets converted to fat?
Sir, excess intake converts into free
what
fatty
form it
acid.
is stored?
Free fatty
Triglycerides,
acid.
sir.
And
So this is supposed to be the pathophysiology of obesity. Okay, that can be asked questions like this. So excess calories are stored as fat in adipocytes in the form of triglycerides. Okay? That is the answer that you have to say. What happens to the adipocytes when fat gets stored in them?
they increase in the size and number.
Increase in size. but not in number initially. Okay.
Yes, sir. Yes, sir.
So beyond what class of obesity, it may increase in number also.
Morbid, more
Morbid
than
obesity,
BMI
they
40.
keep, yeah. So adipocytes increase to a maximum size up to a BMI of 40 kg. Then begin to divide to increase in number in clinically severe obesity, that is morbid obesity cases. So until second class 2, when it is 35 to 40 kg per square meter, the size of adipocyte only will increase. But beyond that, it becomes multiplication also occurs by division. Okay. So that is the difference in the pathophysiology between class 2 and class 3 or morbid obesity. Why central obesity causes more metabolic effects? People who have a big paunch or a central obesity of belly, why it is more harmful than fat deposited in the gluteal region or in the thigh or in the upper arm?
They are associated with increased oxygen consumption, sir.
How?
The intra-abdominal fat.
Abdominal fat. Does fat require more oxygen? So the answer for that is storage of triglycerides is regulated by enzyme called lipoprotein lipase, whose activity is more in abdominal fat than in the hip fat or thigh fat or the arm fat. Okay, so that is the reason why it is not because of oxygen consumption or anything. It is because of the hyperactivity of the enzyme lipoprotein lipase. Okay, this is the reason for higher incidence of metabolic disturbances in patients with central obesity. How does insulin resistance occur in obesity? Normally, people who become obese, they gradually become diabetic also because of insulin resistance. What are the reasons for the insulin resistance to occur when a patient becomes obese?
So when they became obese, the requirement of insulin is very high.
Requirement of insulin is?
Very high. The availability of insulin will be less when compared to the body weight. So there will be relative deficiency of insulin.
Insulin requirement is high, means that means the demand is high, but resistance means normal insulin produced is not able to act in its normal way. That is called the insulin resistance. So the reasons are fatty infiltration of pancreas and liver leads to decreased secretion of insulin, not increased secretion of insulin. Okay, that is the first reason. Fatty infiltration of pancreas and liver leads to decrease in insulin secretion and utilization. Then these adipocytes, which become enlarged, they secrete lot of inflammatory cytokines called IL-1, IL-6, and TN tumor necrosis factor alpha, which decrease the secretion of another hormone called adiponectin, which is a powerful insulin sensitizer. Okay, then normally this adiponectin in our body only causes insulin to become more sensitive and act on the target site. So there is a decrease in the secretion of adiponectin, which is the main insulin sensitizer even in the normal person. And the third reason is leptin, which is secreted by the adipocytes, the hormone for satiety, that is satisfaction after eating a moderate quantity of food. This modulates energy expenditure and food intake by acting on the hypothalamus. Then leptin resistance also develops in obesity. That means the leptin is not able to produce that satiety feeling, leading to patients feeling hungry and not fully satisfied. They go on increasing their intake, and this also increases the insulin resistance. So decreased insulin production because of fatty infiltration, increased inflammatory cytokines, decreasing adiponectin, which is a sensitizer, and leptin alteration or leptin resistance leading to overeating. Okay, these are the three reasons for the insulin resistance. Why obesity leads to constant state of inflammation? I told you here the second point is adipocytes secrete lot of inflammatory cytokines. What is the reason for this state of constant inflammation?
It's a pro-inflammatory state.
Pro-inflammatory. Yeah, that is why inflammation occurs. The fatty infiltration of omental adipocytes leads to influx of free fatty acids, hormones, and cytokines. Okay, omentum becomes fully infiltrated with fat. This also leads to influx of free fatty acids, hormones, and cytokines. This stimulates liver to produce LDL and apolipoprotein B, and this leads to insulin and polypeptide production, causing diffuse intracellular inflammation. That is the increased production of low density lipoprotein and apolipoprotein B. These are all some of the pathological points which you have to remember as a part of the pathophysiology of obesity, which may be asked in the examination. What is the role of genetic factors in causing obesity? Why there is a tendency for familial obesity in some patients? Which genes are all affected? No idea. Mutations in the gene controlling hypothalamic melanocortin receptor, which is involved in appetite suppression. Okay? So basically, as I told you, increased intake and decreased expenditure of calories. That is the basic mechanism for obesity. So this gene melanocortin receptor is one of the important things for appetite suppression. So when that gene is mutated, this receptor behaves differently, making the patient feel hungry all the time and make them overeat. Similarly, homozygous mutations in genes responsible for the two enzymes or two hormones rather, leptin and ghrelin, which are the leptin, as we saw in the earlier slide, is a hormone of satiety, and ghrelin is the hormone for stimulating the hunger. So these two should be in a balance. You should feel hungry with the help of ghrelin, and you should feel satisfied after taking adequate quantity of food by the action of leptin. When this balance is altered by decreased activity of leptin, which cannot produce adequate satiety, and increased activity of ghrelin, which causes hunger all the time, then you tend to eat more and you become obese. And this is very common in childhood obesity. Okay, so these two are the factors which you have to remember. One for adult is the melanocortin receptor mutation, which is a main receptor for appetite suppression. So patient feels hungry all the time, goes on eating. Whereas in childhood, there is an imbalance between leptin and ghrelin, which causes the overeating, which again leads to obesity. What are the systemic effects or system-wise effects of obesity? This is a common thing. Based on this only, you have to ask your history. So what will be the effect of obesity on cardiovascular system, respiratory system, renal system, liver, musculoskeletal? So like that, you have to remember the effects of obesity on the various systems. So, but first system, we will start with cardiovascular system effects. What are the cardiovascular system effects?
So because of chronic CO2 retention, patient will have systemic hypertension, left ventricular hypertrophy, and it will lead to left ventricular failure, sir.
Here also can happen.
Because of OSA, pulmonary artery hypertension, right ventricular hypertrophy, and right ventricular failure. They can have biventricular failure.
Biventricular leading. Okay, if combined with OSA, it can lead to biventricular hypertrophy. Very good, correct. So, what endocrine pathologies happen in obesity? So, like that, you have to remember each and every system. So, I have not given it quickly. I think it will come to later. What endocrine pathologies can happen in obesity?
Because of insulin resistant diabetes.
Diabetes is there. Okay, then
Dyslipidemia.
dyslipidemia, which is an endocrine pathology, the metabolic pathology.
Hypothyroidism can happen.
Thyroid, in thyroid deficiency, usually hypothyroidism. Cushing's also is very, very common.
Cortisol.
So metabolic syndrome, DM, Cushing's, hypothyroidism. Okay, these are the four things. What is metabolic syndrome? For that, I will come to that a little later. What are the gastrointestinal pathologies associated with obesity?
So they can have
Gastroesophageal reflux disease.
ERD. Okay, NASH, that is non-alcoholic steatohepatitis,
Fatty liver.
hernia, fatty liver, gallstones, and gastroesophageal reflux disease. So you must ask the history of all these things when you take the history in a live patient. Okay. So first ask about cardiovascular system effects of hypertension and therefore tolerance, etc. Then go to endocrine, then gastrointestinal, musculoskeletal disorders. What are the musculoskeletal disorders which are common in obese patients?
Sir, increased osteoarthritis. There will be compression fractures.
OA, knee, backache, and inguinal hernia. Okay, hernia because of the weakness of the inguinal abdominal muscles, that also produces a very common disorder. Respiratory system.
So
Type
obstructive
of respiratory disorder it produces. Obstructive or restrictive?
restrictive lung disease.
Restrictive disorder. Okay, so it produces restrictive lung disease due to added weight in chest wall, thoracic cage, and abdomen. Decrease in FRC due to impedance of decrease in the descent of the diaphragm, and even the TRV and TLC are also decreased. Okay? And lastly, closing volume may exceed FRC, which will lead to VQ mismatch. And right to left intrapulmonary shunting will lead to arterial hypoxemia. So these are all the respiratory system deficiencies or disorders. Serious effects, already we have seen systemic hypertension due to insulin effects on sympathetic nervous system and extracellular fluid volume. And also adipocytes activate release of angiotensinogen, which acts on the RAS system, that is renin angiotensin aldosterone system pathway, resulting in sodium retention, which is also another reason for the systemic hypertension. And the cytokines, they also damage the arterial vessel wall, leading to fibrosis and stiffening, leading to hypertension. So there are three reasons for the development of hypertension, which we have seen, we have to remember. And uncontrolled hypertension leads to concentric and eccentric LVH, causing heart failure, and also pulmonary hypertension is again secondary to OSA. How much increase in cardiac output can happen when the patient starts gaining weight? Per kg of weight gain, every 1 kg, how much increase in cardiac output happens? Yeah.
No,
So
sir.
it increases by 100 ml per minute for each kg weight gain. Okay, so that is another workload on the heart will be increased by 100 ml per minute for every increase in kg body weight beyond the normal weight. What causes coronary artery disease in obesity? Why obese patients are more prone to coronary artery diseases?
The adipose tissues have more blood flow.
Adipose?
Accelerated atherosclerosis.
PAD in obese patient due to, as we saw, chronic inflammatory state, dyslipidemia, hypertension, and diabetes. And diabetes leads to progressive atherosclerosis. So all these four factors, chronic inflammation, dyslipidemia, hypertension, diabetes. If these things are all absent and patients are obese, this is called a simple obesity. They don't suffer from coronary artery disease. Whereas when obesity is complicated by these four other metabolic and systemic effects, then patients will develop atherosclerosis faster and they will go for coronary artery disease. Now, this The reason for giving all these questions is you must be aiming to get the answers from the history of the patient for all these pathologies which can affect the patient. Okay, that is the reason for asking this so many questions on pathophysiology. So you must try to elicit the answers for all these things. And in examination, you must do a general examination and systemic examination, especially always start with the airway first, because that is supposed to be the most challenging thing as an anesthesiologist for us. So in all obese patients, first describe the airway and see whether the patient is already suffering from OSA, and venipuncture may be challenging in obese patients. So suitable IV site, IV access site should be examined and marked. Spine should be examined for any possibility of giving central neuraxial blockade and features of metabolic syndrome. Okay. Now, what are the features of metabolic syndrome? This is a very common question that examiners may ask you, especially if the patient has a big belly or a big paunch, which is common central obesity feature of metabolic syndrome. What are the other features?
Insulin resistance, dyslipidemia, and hypertension.
Central obesity. Okay, increase in waist circumference, which is called central obesity. That is the first point. Then hypertension, then insulin resistance, then decrease in HDL, increase in triglycerides. So the good cholesterol is lowered, triglycerides are increased, there is insulin resistance, hypertension. These 5 factors contribute to metabolic syndrome, but all the 5 need not be there. 3 out of the above 5, if it is present, then metabolic syndrome is supposed to be present in that. And the diagnosis, we should make a diagnosis of the obesity class. Whenever the BMI is not given, sometimes they may give you the height and weight alone. Then you must quickly calculate the BMI and first describe to which class of obesity the patient belongs. Then go for the associated complications and whether they are controlled or uncontrolled. So this will be the pattern in which you should put your diagnosis after taking the history and examination of the patient to conclude your history taking and examination. Now, this is the common thing which all of you should be knowing. Underweight is less than 18.5 BMI. Normal weight is 18.5 to 24.9. Overweight is 25 to 29. Class 1, 30 to 34. Class 2, class 4, which is supermorbid obesity. Okay? And what are the associated complications? Systemic hypertension, DM, OSA, and you must also find out the effort tolerance and other endocrine disorders, hypothyroidism or Cushing. All this should be mentioned in your final diagnosis of the patient. So don't just stop with the BMI and the class of obesity also. Always mention about the associated complication and whether the patient is under treatment for hypertension or diabetes, whether the comorbidities are under proper control or not also should be mentioned in your final diagnosis. Now, what are the pre-op investigations you want to do in this case?
So routine investigations like complete blood count, renal function test, serum electrolytes.
All you can to quicken or make it faster. We'll always say surgical pack or surgical pack, which is a common thing which is done in all the corporate hospitals, which will include CBC. So we will not be repeating every time in all the other subsequent discussions. So surgical pack, anything special other than the surgical pack?
So based on the functional status, effort tolerance, we can ask for stress ECG. So
echo, if there is a
pulmonary function
suspicion
test
of
and
coronary artery disease, okay.
pulmonary function test and
So routine
baseline.
LFT, RFT, ECG for LVH, RVH, IG, CXR for heart and lung fields, echo for heart chamber dimensions, systolic and diastolic function, and PhD. Polysomnography if OSA is diagnosed for the first time. Okay? This is a very important point you have to mention here. examination. For that, you should ask the question routinely. All of you know how to identify OSA by the
Stop
what is a stop bank questionnaire. All of you are aware of that. So always ask all obese patients given in the exam about whether your family members. First, start with the question: are your family members complaining that you snore a lot during night hours sleeping? And have you ever got up feeling choked? These two questions will immediately give you the answer whether the patient is a habitual, just a simple snorer or a OSA patient. If he wakes up with a startle, getting choked, that is OSA. If he just makes a loud noise but never wakes up, that is a heavy snoring. That's all. Okay, so that is the difference between snoring and OSA. And the ABG breathing room air is also one of the important investigations which we have to mention. On risk stratification. So after examination and the investigation, always you do the risk stratification. How do you stratify the risk in these patients?
Obesity surgical mortality scores.
There are a lot of points which you have to take into consideration. First, the class of obesity, then airway difficulty, presence of metabolic syndrome, systemic hypertension or ischemic heart disease, and if the patient has any uncontrolled diabetes, previous DVT, restricted mobility. All these things are points to consider, and based on that, you stratify the risk. And also pre-op optimization. What is if supposing OSA is present, what is the important pre-op optimization you have to do? Diagnose for the first time.
CPAP therapy.
You have to correct it by attempted weight reduction, exercise, breathing exercise, and control of comorbidities. And patient should be initiated on CPAP or BiPAP if OSA is also diagnosed for the first time. And pre-op instructions.
Sorry.
Continue with the medicines. OHA, only ACE, ARB, antiplatelets to be discontinued. But this protocol to be withheld and administered on the day of surgery. Then NPO, anti-aspiration prophylaxis, very, very important because these people are also considered as full stomach patients. All patients, especially with central obesity and history of GERD, they are more prone for aspiration. So anti-aspiration prophylaxis is very important. And to bring their CPAP or BiPAP equipment to the hospital. And if there is a previous history of DVT, they could be started on low molecular weight heparin or heparin depending upon the history. And sometimes you may have to think of IVC filter also. If the previous DVT has been very severe, you have to think of putting a greens filter in the IVC to prevent post-op embolism thrombosis. How do you manage these patients intraoperatively for the surgery of liposuction and abdominoplasty?
So general anesthesia with endotracheal intubation.
The abdominoplasty and liposuction of the abdomen, does it require general anesthesia? It is usually it will be like a fan and steel incision, dissecting the abdominal wall. They don't go inside the abdomen. They pull it and the excess fat is cut off and then the abdomen is sutured. So you have to plan for intraoperative management. You have to decide between regional and GA based on the airway, patient position, duration of surgery. These three factors have to be taken into consideration. If the patient has a difficult airway, then regional will be a better choice, provided you can identify the landmarks well. And the patient should be able to lie on his back because this abdominoplasty and liposuction, they will be in supine position. So you may need to give them a little bit of head-up tilt so that they can breathe easily. And the duration of surgery, you must have a discussion with the surgeon and decide how long it may take. And based on that, you have to decide which type of anesthesia you are going to give. What are the advantages of regional in these obese patients? You plan to
Sir,
give put a epidural catheter, and then you can give anesthesia for any number of hours with the catheter. That is the plan that you are making. What are the advantages?
sir, there will be no airway manipulation.
First and foremost, you are avoiding any airway manipulation. Especially if it is going to be a difficult airway, you are going to avoid the manipulation of airway, and the aspiration risk is not there, and less use of opioids, so less respiratory depression. So patient is always conscious and maybe only sedated if required. So these are the two important advantages. But how are obese patients with anticipated difficult airway managed? Supposing they have a short neck, they have a large tongue, and you anticipate malambati grade 2, 3, or 4. If that is the situation, how are you going to plan? And the patient insists that they don't want any regional and they want only GA. So if that is the situation, how are you going to manage or plan for the management of the difficult airway?
Sir, we have to make the difficult airway cot ready, and we have to get assistance and help. We can try it with direct laryngoscopy, and we have to get the video laryngoscopy standby. If we are not able to do it with direct laryngoscopy, then we can go with video laryngoscopy.
Okay.
With a single dose of succinylcholine.
Okay. What is the
Positioning,
position you
sir,
want
in
to
the
keep the
ramped
patient in?
position.
That is the first thing you must say. Okay, RAM position, assistance, trial scopy, and then if difficult, video laryngoscopy. But if clinically considered extremely difficult to induce and intubate, what is the best thing to do?
Awake fiber optic.
Awake fiber optic intubation. Okay, so ramp or held position is ideal. Difficult airway cart should be checked and kept ready. Skilled assistance to help with burp maneuver or 2% mask ventilation. Cricothyroidectomy to be kept ready. ENT surgeon presence in anticipated difficult airway, and planned awake fiber optic intubation if it is a confirmed difficult airway. This is a very, very safe method to intubate the patient in a conscious awake state by topicalization of the airway and intubation, and proceed after successful intubation. You proceed with supplementing the general anesthetic drug and go ahead and give the anesthesia. So, how does drug distribution vary in obese patients? I am taking little time for this case discussion because this is one of the common case scenarios we will be given in the examination. These are the common questions you can expect in the exam.
It is based on the lipid solubility and volume of distribution.
The drug is hydrophilic or hydrophobic.
Yes.
Okay. Lipophilic and or hydrophilic. That is the first thing. So lipophilic drugs show increased volume of distribution than lipophilic and hydrophilic drugs that are distributed in the fat tissues and the lean mass. Okay. So the total body weight should be used for lipophilic drugs, and ideal body weight should be used for patients which are more hydrophilic, because there will be the distribution will be limited to lean tissue. What is this lean tissue, and what is the difference between total body weight and ideal body weight?
So ideal body weight is it is a total body weight. It is derived from the height minus
100
for
height in centimeters minus 100 balances in kilograms. That is the formula to calculate the ideal body weight. Okay. Whereas total body weight is what you actually measure from the weighing machine. That is called total body weight. Okay. And so anything excess lean body weight or body weight without fat is called lean. That is mostly muscle and bones. That is called the lean body weight. Whereas if the additional fat that is deposited will add to the lean body mass, which will give the total body weight. Okay. So how does drug metabolism differ in obese patients? So the distribution is decided by the lipophilic or hydrophilic nature of the drug. So lipophilic drugs require larger doses based on total body weight because it will get dissolved in the fat and only limited quantity will reach the effector site. On the contrary, drugs which are water soluble, they will be having a lesser volume of distribution. They will easily disperse, and we have to give it on ideal body weight, which will be much less than the total body weight. Now, drug metabolism, how does it differ? Again, increased level of serum proteins changes the metabolism in obese patient that leads to different half-lives of the drug in an obese patient from a normal patient. Okay? An increase in phase 2 metabolism is also noted, and phase 1 metabolism either increases or remains the same. Whereas phase 2 is always slightly increased, and so these two changes are there. Protein which carry the drugs, there is a change or increase in their level. So when protein binding is more, this will lead to a longer action because it will be slowly released from the protein binding and serum concentration will be maintained. So level and the half-life will be more. And phase 2 metabolism is also increased. So the conjugation and glucuronidation, all these things will be increased and that will be disposed of. So how is ideal body weight calculated? You simply said the easiest way is to take the patient's height in centimeters and subtract 100 for men and 105 for women. You get the ideal body weight in kilograms. But there is a formula which is actually 45.4 kg and 49.9 kg in male plus 0.89 multiplied by height in centimeters minus 152.4. Okay, this is the correct formula to calculate the ideal body weight in kilograms. What is lean body weight? How is it calculated? These are two calculations, your total body weight and ideal body weight. And there is a third body weight which is called lean body weight. How do you calculate that lean body weight?
It is 20% of.
That's a rough calculation. So lean body weight is the person is devoid of all the fat mass, and there is a big formula for that. 9,270 multiplied by total body weight divided by A plus B multiplied by BMI, where A and B are 6,680 and 216 for males, 870 and 244 for females. Okay, those who can remember that, but at least know that there is a different formula to calculate lean body weight instead of just saying 20% of so lean body weight is devoid of all fat masses. So ideal body weight plus 20% is that is supposed to be the usual rough method of calculating the lean body weight. So those are the questions that you can expect from obesity and all about OSA, the effects on OSA, all those things you have to remember. So that was a common questions that are commonly asked in obesity cases, which I thought will be useful. Now we go to the next case scenario. 24 years old primary gravida, 34 weeks of amenorrhea, admitted with severe headache, visual disturbance. Her BP is 180, 110. She was diagnosed to have elevated BP at 26 weeks during antenatal checkup. It was diagnosed as a case of PAH and started on nifedipine 10 mg BD. Now the patient has come with severe headache and visual disturbance. How do you manage this patient? So first analyze this case as we did in the last discussion, last class. First of all, what are all the challenges you face in this case?
She's in the preterm, it is 34 weeks of amenorrhea, sir.
Primary in her third trimester of pregnancy. So the most important thing is about fetal prematurity. Okay, after 36 weeks, we say the fetus is mature enough to survive when born. Whereas at 34 weeks, there is still fetal prematurity is there. Okay, then
She
It's a
has
case of
signs of
preeclampsia
severe
with severe
preeclampsia.
features.
she has signs of BP is high and she is symptomatic. Okay, that is the second challenge. Then what is the important complication you want to avoid in this patient?
Eclampsia.
Eclampsia. So PA is diagnosed at 26 weeks of gestation. Details of BP at the time of diagnosis, whether there is proteinuria or not, that has not been given. So we have to find out if there is proteinuria to establish whether she is suffering from preeclampsia or a simple gestational hypertension. That differentiation has to be made. Okay, so that is the important thing. So what are the pre-op evaluations you will do in this case?
Sir, all baseline investigations along with ECG, echo, urine routine to look for urinary protein and glucose. We have to get ophthalmologist consent for fundus examination.
Okay. So when the patient had regular evaluation of BP after initial diagnosis of PH at 26 weeks, was she regular in taking the medication? Any urine protein test done? Does she have any right hypochondrial pain? Why this question is asked?
Because of
Fetching of the Gleason's capsule.
Periportal
Whether it is
hemorrhage.
a health syndrome, okay,
Health
early
syndrome.
indicator of HELLP, health syndrome. The assessment of fetal welfare by daily fetal movement count, non-stress test, biophysical profile scoring. Okay, so whenever mother has got preeclampsia, you have to also take care of the welfare of the fetus. And the three important tests that are done to assess the fetal welfare are daily fetal movement count. Mother will start feeling the movement of the baby. So how many times the baby moves, she has to make a note and tell the doctor to assess whether the baby is active, non-stress test, and biophysical profile scoring. All these things, three tests are the common questions that they will ask you to find out the viability and welfare of the fetus. Investigations will do the routine plus urine protein creatinine ratio, specific gravity, urine examination for any epithelial cells, RBCs, partial, urine uric acid, RFT, LFT, coagulation profile, and fundus examination. Okay, apart from all the routine. So whatever ECG, CBC, all that will come under routine. Now, what is the dilemma in this case? Now, she is symptomatic, she is having a severe headache, visual disturbance, BP is very high, and she is 34 weeks amenorrhea. So, baby is still in a little premature state. So, what is the biggest dilemma in this case? Whether we should deliver the baby or whether should we continue with the pregnancy?
Termination of pregnancy will be the cure for preeclampsia.
Straight away? Don't
so
give
we can
any
observe
We
her,
can
we
So,
can we
for
can
fetal
observe.
non-maturity, we have to give
Now, what is the
betamethasone.
first step you will answer? This patient has come to the OP with headache, visual disturbance with a BP of 180, 110. Will you immediately take her for delivery?
So
No,
we have
sir.
to
have to
give
We will
admit the
control her
patient
betamethasone
and
for
BP
control
fetal
the
and
bleeding.
You
the
can
seizure
try to treat
prophylaxis.
that high blood pressure, isn't it? First and foremost, try to bring down the blood pressure by treatment. You have not tried the treatment at all. Now she has been given oral benefit. So how to control this BP? What will you do?
the magnesium sulfate, labetalol IV can be given.
First thing, admit the patient. Okay, she has come to the outpatient now. This is the finding that has been done in the outpatient department. So, dilemma is maternal safety versus fetal safety. Is there a risk of eclampsia? If yes, immediate delivery is imminent to save the mother. If no, can pregnancy continue till 36 weeks to allow the fetal maturity? If planned for delivery before fetal maturity, administer betamethasone for lung maturity and careful monitoring of the mother of the fetus. But before you take a decision on all these things, Your answer should be first admit the patient, try to control the BP with parenteral antihypertensive drugs. And that is what you mentioned as labetalol, hydralazine, all those things have to be given. So you should gradually reduce the BP, and if he responds well and their symptoms abate, like the severe headache, visual disturbance, all of them vanish, then you can monitor the fetal welfare and allow the pregnancy to continue, and start her on prophylactic magnesium sulfate also for future prophylaxis, and allow the baby to get mature some more up to 36 weeks and then decide on that. So these are the things that you have to take after reducing the BP by admission. So management is control the high BP by admission, frequent monitoring, parenteral antihypertensive drugs, magnesium sulfate for seizure prophylaxis. So this is the first answer that you have to give after seeing the response of the mother. If the BP comes down within normal range and mother is feeling asymptomatic with no headache, then you take a decision on allowing the pregnancy to continue till 36 weeks to give the fetus a better chance of survival, to allow it to become more mature. Okay, that is the thing that you have to do. And if normal labor is safe, if the physician feels that you can do a normal labor itself, then permitted adequate pain relief from the early stage of labor itself you have to think of by providing adequate labor analgesia. But if operative delivery, RA is always safer with modifications. What are the modifications you can do? The ideal technique for cesarean delivery is single shot spinal anesthesia that we normally practice. Can you do the same thing for the mother with the preeclampsia?
So we can give a combined spinal epidural with low dose of spinal.
Very good. That is one option. Supposing there is a fetal distress and the physician says they don't have time for you to do the combined spinal epidural, it may take a longer time. They insist that you do a single shot spinal.
Rapid sequence spinal.
Rapid sequence spinal with what is the modification you have to do in the drug dosage? You do
Sir, we have to give a plain local anesthetics without any opioids to have faster onset and dense blocking.
You are saying the other thing.
OPI
Here don't
and
you have
OPI
normal volume of local anesthetic. How much of local anesthetic, what local anesthetic you administer for a regular cesarean?
0.5% bupivacaine.
2 ml, sir.
0.5% heavy bupivacaine. How much ml you give? How many ml you give?
2 to 2.5 ml.
2 to 2.5 ml. Okay. Instead of that, for patients with preeclampsia, it is advisable to go for 1.5 ml of 0.5% heavy bupivacaine with 25 mics of Saturday, which will be again 0.5 ml. It will make a total volume of 2 ml. Okay. So instead of giving the 2 or 2.5, which you give regularly for preeclampsia patient, it is safer to give 1.5 ml of 0.5% heavy bupivacaine with half a cc, which contains 25 micrograms of fentanyl, and manage the patient. That will take care of the, even if the level goes only up to T10 or T8 instead of the T4 or T6 which is required, the fentanyl will take care of the pain that is caused by the fundal pressure. Okay. So the modification is operative delivery is planned with RA, low dose spinal with opioid, combined spinal epidural, or titrated epidural with a catheter. These are the three choices depending upon the other conditions and time available. If the patient is in fetal distress, then single shot spinal with opioid will be a much faster and safer technique. But if GA is required, how do you manage with the GA? What precautions you have to take with GA?
Sir, we have to provide rapid sequence induction.
Very good.
We have to avoid BP fall during induction and sympathetic response during intubation. By
Both
giving
hypo and
drugs.
hypertension have to be managed or prevented rather. So, VA is required. Initial adequate control of BP is important during induction, and intraoperative prevent the increase which will cause cerebral bleed, the main cause for mortality. So prevent intraoperative rise and hypotension during induction, and always give about 20-degree head up tilt, and titrated induction with propofol will be good, and rapid sequence induction using either acamtonium or rocuronium, and avoid any intraoperative rise in blood pressure by adequate analgesia also. Okay.
Yes, sir.
So that is another common case scenario that you will get preeclampsia patient coming with symptomatic hypertensive crisis, coming whether to go for immediate delivery or wait and watch delivery. So that is the discussion that will be commonly given. The next case scenario is a 72 years old post-CABG patient posted for right inguinal hernia. So this is a case of treated CAD. So how do you manage this patient? What are the things you want to first analyze the case?
So is an elderly patient.
Elderly patient. So geriatric age group.
Geriatric age group. Known case of CAD. So he's at risk of peri-op MI and he'll be on anticoagulation.
First of all, we must know the history. When he was operated, how long, how many grafts were put, okay, all the details you have to know. So first point is he is a geriatric patient. Post CABG for IHT. So get all the details when CABG was done, how many blocks were there. And third is a herniorrhaphy, which is a simple surgery done as a daycare procedure. So these are the three things that you get from that. So what is the important history you want in this case?
So when was he diagnosed with CAD and what was the symptoms he had? How many grafts were kept? And on what anticoagulants he is on? Whether he had symptoms after CABG and its functional capacity now.
Tolerance, very good. So information needed are age-related problems because it's a geriatric age group. Second, any other comorbidities other than this coronary artery disease. Status of IHD, medications, effort tolerance. Hernia, whether it is reducible or irreducible, any previous obstruction. So these are all the information. And last, voiding difficulty or chronic cough as a cause of hernia. Okay. So these are all the information that you should get. What are the pre-op evaluation, investigations, and the instructions you will give for this case?
Airway examination.
Routine pre-op evaluations, or as you do for any other case, all the each and every system like cardiovascular, respiratory, hematobiliary, musculoskeletal. Okay, so do all that, and so general examination including airway, dentition, back and spine. Then cardiac status, number of years since undergoing CABG, any recurrent angina, effort tolerance, antiplatelet continuation, functional status of the graft by echo. These are the pre-op evaluation. Investigation, you have to do EKG, echo, CBC, RFT, coagulation profile, and USG of hernia to identify what are the contents in the hernia. And pre-op instructions, discontinuing long-acting and antiplatelets like clopidogrel if he is taking, you have to wait for 5 days and think of whether you need any substitute. And of course, you can always continue aspirin. And if planned as a daycare, advice for pre-op sedation at home, previous night with alprazolam, NPO instruction, continuation of any antihypertensive therapy if he is taking, what antihypertensives you should inquire and give instruction accordingly. That normally ACE and ARBs we stop 24 hours prior to surgery. Okay? So these are all the common things that we have to remember. And intraoperative management of this case.
Sir.
What is the anesthetic technique choice?
Sir,
can you give a regional because it's only a hernia?
Whether it is open or laparoscopy.
Okay. Supposing it is an open hernia.
Based on the surgeon, we can go with spinal or combined spinal epidural.
So, intraoperative management, you can think of single shot spinal, epidural, or combined spinal epidural. So, the main point you have to remember is there is no contraindication for a central neuraxial blockade in a post-CABG patient, provided his cardiac function, effort tolerance, and the antiplatelet agents are all acceptable. Okay, there is no coagulation profile because of activation of antiplatelets, and his bleeding and clotting time ANR are all normal, and his effort tolerance is normal. The grafts are functioning well, and he has been having a normal cardiac function. Then there is no contraindication for giving a central neuraxial blockade. This point is important both from your future practice as well as for examination purpose. But make sure that you don't cause a sudden hypotension by giving a large volume of local anesthetic and keeping a level very high. What you need is only a level up to T10. You don't require for a hernia surgery any level more than that. So don't produce a very high level and cause a acute hypotension. That is the only precaution that you have to take. And GA, if patient refuses or infection is present or altered coagulation, or if it is planned for a lab procedure, then GA is indicated. What are the main goals in the management?
So to avoid tachycardia, to maintain normal sinus rhythm.
So avoid hypoxia, hypotension, especially diastolic hypertension and tachycardia. Okay? These are the two important things. What questions you can expect in these cases are anatomy and control of coronary circulation, acute coronary syndrome. What are the types? What are the types of acute coronary syndrome?
Sir, unstable angina and myocardial infarction.
What are the types
ST
of
elevation?
ST elevation. Three things you must say. Unstable
yes,
angina, MI, non-ST elevation MI, and ST elevation MI. Okay? These are the three things. Clinical features and management, anesthesia for CABG, pathophysiology of coronary artery disease, ECG interpretation of MI, drug therapy post-CABG and their adjustment, methods of assessing effort tolerance. How do you assess the effort tolerance?
Sir, by history, we can take metabolic scoring, metabolic equivalence.
Okay.
Then we can do a
6-minute walk test is a very objective
test.
method. You can ask them to walk minutes in the two distance of 100 meters, and or you can ask them to do even a treadmill. Okay? All those are effort tolerance. Diagnosis and management of intraoperative MI. Supposing the patient is undergoing surgery and unfortunately intraoperatively he develops an MI, how will you diagnose? Under regional, under the GA, both you have to know.
For regional, we can ask the symptoms of chest pain.
Okay. Supposing patient is under GA,
we can do a 12-lead ECG intraoperatively.
Yeah. So ECG monitoring, 5-lead ECG monitoring is very, very important. So make sure that you can identify intraoperative immediately. And all about daycare surgery, because this is a simple surgery which can be done about daycare. So instead of asking about MI coronary artery disease, the examiner may suddenly ask the student all about daycare. How do you select the patient? What are all the criteria to decide the patient? What are all the requirements to do a surgery at the daycare? All those questions you have to be prepared. Okay? Now the next case scenario is a 62-year-old lady, known case of bronchial asthma, hypertension 10 years, has a lump in the left breast. FNAC reported showed adenocarcinoma. She is posted for left modified radical mastectomy with axillary clearance. So this is a known bronchial asthma patient, hypertensive patient coming for a cancer surgery. So analyze the case.
She is an elderly female.
Elderly female. So 62 years belongs to geriatric group. Then
she has bronchial asthma, systemic hypertension.
comorbidities are bronchial asthma, hypertension. Then
she has a malignancy.
CA breast stage not known. Neoadjuvant therapy details not known. And because it's an approved adenocarcinoma, you cannot wait for too long. Okay, so these are the three important things that you have to. What in history you want in this patient?
Sir, for bronchial asthma, how long she is a known bronchial asthma, and when was her
Duration
last
of bronchial
exacerbation?
asthma, okay.
How
will you assess the
frequently
severity of
she is,
bronchial asthma?
how frequently she is taking
frequent attacks, and how much of what the drugs she takes to get relief of that attack. Okay, so history
and when
taking.
was
First of all, chronological biological age problems, and duration, severity, treatment, and control of comorbid conditions, both bronchial asthma and hypertension. Duration of malignancy, any pre-op chemo or radiation therapy taken. That is also important thing. Why this question is important?
So they can have airway and cannulation problems post chemo and radiotherapy.
Radiotherapy, very good. The pre-op evaluation, investigation, and instructions.
So to review our medications to assess our functional status, general examination, systemic examination, especially is cardiovascular and respiratory system to look for any added sounds or whether she is active.
Examination, BP control, bronchial asthma status, drug therapy. Okay, you can just summarize this into these four categories. Then, if neoadjuvant therapy with regard to cancer, if neoadjuvant therapy given effects of chemo and radiation on various systems. Now, pre-op investigations as a routine for any surgery, evaluation of CVS and RS due to hypertension and PA. Pre-op instructions, NPO, medications for hypertension and BA to continue or to withhold, depending upon the drug that she is taking. Okay. And in anti-anxiolytic, anti-aspiration drugs, whether IV fluid is needed, any pre-op nebulization to be given. All these instructions we have to give. Okay. Now, what is the intraoperative management? GA versus RA. What are the choices you have? If you are going to give GA, what precautions you will take? What are the various RA now people are practicing for breast surgeries? What is the most important complication you have to keep in mind if you are going to give GA for this patient?
She has a reactive airway. So
that is the answer. You have to think of reactive airway. Okay, so intraoperative choice of anesthesia, GA with EP tube or thoracic epidural anesthesia with thoracic epidural anesthesia for pain relief. Or you can go for anterior approach blocks, which include pectoral, pec major, pec 1, pec 2 blocks, serratus anterior plane block, intercooler, interpersonal block. Okay? So posterior approach blocks. So regionals can be divided into anterior approach and posterior approach blocks, which include thoracic epidural, paravertebral, and director spinae blocks. Okay. So thoracic segmental anesthesia also is one of the choices as regional anesthesia. So minimum pain permission local anesthesia injection for wide awake modified radical mastectomy. This is the latest technique that has been published in the journals. So for those of you who perform very well in the examination, the examiner might give you additional marks if you mention this. Minimal pain permission local anesthesia injection for wide awake modified radical mastectomy. Now, what questions you have to expect this are treatment of bronchial asthma, management of intraoperative bronchospasm. I'm not going into details because we already have discussed about the tight bag and other things in the last class. And control of hypertension and all about hypertension anesthesia. Chemo drugs used in treatment of breast cancer and their implications on various systems. Radiation and its effects, which will interfere with the anesthetic technique. Nerve supply of the breast and areas of surgery because the regional anesthetic technique. Methods of performing anterior and posterior chest wall blocks. They can suddenly ask you one of them. All about permission local anesthesia because of the recent on what about segmental spinal anesthesia? Any idea what is this segmental spinal anesthesia? How to perform this?
They use plain bupivacaine instead of heavy bupivacaine.
At what level? Normally, any thoracic epidural catheter or any thoracic spinal anesthesia, what is the normal level chosen? It's between T7 and T9. But for segmental spinal anesthesia, you choose the interface between T3 and T4 or T4 and T5 and deposit just 1 ml of plain bupivacaine, not heavy bupivacaine, and that is supposed to take care of the segments that are applying the breast area that can be performed without any problem. Okay, that much of knowledge is enough. The next case scenario is 42 years old lady complains of severe bleeding per vaginum, posted for abdominal hysterectomy. She has been diagnosed to have a pheochromocytoma 3 months back and now has a BP of 220 by 130. She is posted for abdominal hysterectomy. First analyze the case.
Patient has severe bleeding, so
Bleeding
she can
per
develop.
vaginum. So we do not know her hemoglobin status. Okay,
Yes.
very good. Patient with bleeding PV, duration of bleeding and their effect on this. Okay, get good.
Then she has a pheochromocytoma.
Recently diagnosed pheochromocytoma, BP is still high, so need to evaluate and control that also. Okay.
Yes,
and decision regarding performing in abdominal vaginal is not vaginal hysterectomy, abdominal hysterectomy with suprarenal excision in the same sitting or separately. Okay.
Yes, sir.
Now, what history you want to take in this patient?
Sir, history pertaining to bleeding, whether she has fatigability, palpitation.
Very good.
She has
Okay. So history, duration,
dizziness.
and quantity of bleeding PV. Any symptoms of acute anemia like tiredness, breathlessness, decreased effort tolerance, giddiness, and how pheochromocytoma was diagnosed by symptoms due to hypertension or incidentally, because sometimes patients with pheo may be totally asymptomatic also. Not necessary they should all have a severe hypertension and the effects of hypertension. And what investigations done to confirm the diagnosis of pheo? What treatment she has already received for that? Any surgery advised for that? Okay? These are all the history that you should take in this case of combined comorbidity of pheo. What investigations you want to do?
So routine investigations along with the ECG, chest X-ray, echo.
That all comes under routine only. All surgery track will carry all that, no? Okay.
Yes, sir.
PGC,
Blood group and
creatinine,
type.
RFT, LFT, investigations pertaining to PPO. What are the PO investigations you have to do? PO chromocytoma.
Sir, ultrasound abdomen,
What is that?
serum catecholamines level, urine metanephrines.
Excellent, very good. What are the pre-op optimization you have to do?
Sorry, if it is acute anemia and severe anemia, we have to transfuse blood prior
Correction of
surgeries.
hemoglobin, very good. Okay. Then
We have to control the blood pressure.
blood pressure by giving drugs. Okay, very good. Correction
Yes.
of anemia is present to achieve minimum hemoglobin, control of BP, and decision regarding combined surgery and preparation according to, like, starting alpha blocker followed by beta blocker for control of your chromosome of the blood pressure. Okay? These are the three important things that you have to do. What will be the plan of anesthesia?
So, if the patient is stable, we can go with combined spinal epidural.
It is a hysterectomy alone, or it is both hysterectomy and that is the thing which will decide, no, whether it is
Yes,
going
sir.
to be plain hysterectomy or whether it is going to be hysterectomy combined with suprarenal mass excision. Okay? So that is
Yes.
that's the thing. So you can, if it is a combined procedure of both excision of the suprarenal mass as well as hysterectomy, ideal will be to go for GA with epidural or facial plain bomb. Okay? And challenges in the room when you combine it with suprarenal mass excision, what are the cardiovascular challenges you will face when they do the
Patient can
excision of the pheochromocytoma mass?
patient can have both increased BP and hypotension.
Hypertension and post-excision hypotension. As simple as that. So you require more invasive intense monitoring like IBP and CEP, prevention of surges in BP before removal of the mass, management of acute hypertension following removal of the mass, where the patient will go in for hypertension severely, vigilant post-op monitoring till the patient is hemodynamically stable. Okay? So these are all the things that we have recommended. Now, this is another gray area, as I told you in the last class. 26-year-old post-gravida, 22 weeks of gestation, complaints of extreme tiredness and loss of appetite, shortness of breath on exertion. Hemoglobin is 6 grams. How to manage this patient? So, what is this comorbidity complicating the pregnancy?
Anemia complicating
Anemia
pregnancy.
complicating pregnancy. Okay. So, first analyze the patient.
So patient is a multigravida, and she is on her mid gestation. She has a hemoglobin of 6 with
early
symptoms.
gestation, you can say the exact trimester. She is in the second trimester.
Second trimester. She has anemia with symptoms.
Symptomatic anemia. Very good. Multigravida in second trimester. Symptoms suggestive of severe anemia because HP is 6 grams with decompensation. Urgent management needed to safeguard the mother and fetus because this 6 grams is too low for a pregnant woman. Okay? So, how is anemia during pregnancy defined? What is the definition?
So serum hemoglobin level less than 11 grams per deciliter is defined as anemia.
All the time?
So in first and third trimester it is less than 11. In second trimester it is less than 10.5.
10.5 to 32. Okay. So anemia is not a diagnosis but a presentation of underlying condition. Now, how is anemia classified?
Sir, it is mild anemia if the hemoglobin level is 9 to 11 gram per deciliter. It is moderate if it is 7 to 9 gram per deciliter. 4 to 7 is severe. Less than 4 grams is very severe anemia.
Anemia has many classifications. What you are saying is about the severity of anemia. But anemia per se, how to classify that? Can be
Based on
etiological.
etiology. Yes, sir.
Okay. So comes under physiological, can be acquired, nutritional, infection, hemorrhage, bone marrow suppression, renal disease. Genetic, it can be sickle cell or thalassemia. Morphological classification is microcytic, normocytic, and macrocytic based on the size. And what is ICMR classification of anemia? This is where your values come into play.
Yes,
Where it
sir.
is mild, moderate, and severe, very severe. Okay, so based on
Yes, sir.
severity, that is only this is the third classification, not the original one. So ICMR mild is 10 to 10.5, 10.9, moderate 7 to 9.9, severe is less than 7, very severe is less than 4 grams. So there are 4 grades: mild, moderate, severe, and very severe. And our patient comes under which category?
Severe anemia, sir.
Severe anemia, not very severe, because it is between 4 and 7, 6 is severe. Okay. So how to detect absolute iron deficiency, which is the common cause of anemia? Iron sequestration, inadequate iron stores, and maturity factor deficiency.
So
They're
we
all
have to do complete blood
tested.
count, peripheral smear, total iron binding capacity,
No,
serum ferritin.
individually these 4 conditions, if you want to diagnose, what are the specific tests you will do? You will
Serum
do
iron, serum ferritin, and total iron binding capacity.
So absolute iron deficiency, you have to do first ferritin examination. Ferritin level less than 30 or ferritin less than 100 combined with transferrin saturation of less than 20% or a C-reactive protein elevation of more than 5 milligrams per liter. Okay? So these 3 conditions are important to diagnose absolute iron deficiency. For iron sequestration, where it is not utilized but deposited in other tissues, ferritin level will be more than 100, saturation will be less than 20, and C-reactive protein also will be more than 5 milligrams. And iron inadequate stores, ferritin less than 100 nanogram without anemia. And maturative factor, vitamin B12 will be low and folic acid will be low. These are the 2 maturative factors which are there in there, which are required for normal RBC production. What is the normal value of ferritin in pregnancy?
It's more than 250, sir. 350.
Yes, 14 first trimester 14 to 133 nanogram per ml. Second trimester around 20 microgram per liter. Okay. What is the transferrin saturation? What is the value in pregnancy?
It is the percentage of transferrin.
Already all the answers are here.
Ferritin.
So it
Yes,
is
sir.
the ratio of
Saturation.
serum iron concentration to total iron binding capacity. That is the way you calculate the transferrin saturation. Total serum iron to the total iron binding capacity. The normal transferrin saturation value is about 19 point. It is a percentage. It is not any milligram or nanogram. It is a percentage value between 19 and 65. Roughly remember 19 to 65. Now, in response to anemia, what compensatory mechanisms are activated in order to restore the supply of oxygen to tissues?
So increased erythropoiesis, increased heart rate, and increased
2-3
reticulocyte.
bisphosphoglycerate and rightwards to ODC curve, sir.
So increase oxygen extraction, that is the first compensation. So the tissues start extracting oxygen and shift in ODC curve to the right, and increase capillary flow due to reduced viscosity. These 3 compensations happen. Of course, clinically, patients will have tachycardia, hyperdynamic circulation, because of low HCR and difference in pulse pressure and all those things. But the changes per se, you have to say increased oxygen extraction. How do you find out whether the oxygen extraction is more or normal?
So difference between arterial and venous oxygen.
Mixed venous oxygen saturation.
Venous oxygen
Not just so what are the organs capable of increasing oxygen extraction from the blood?
Brain.
Brain and very good.
Brain and heart.
The tissues increase oxygen extraction. Tissues like kidney, skeletal muscle, skin can increase the amount of oxygen, and that leads to increased total extraction. But the identified by decrease in the mixed venous oxygen saturation. Normally, if the arterial oxygen saturation is 98 to 100%, mixed venous oxygen saturation will be 75%. If it is going down beyond 75 to 60, 55 like that, that means more oxygen is extracted. This is becoming more deoxygenated. So that is how you find out the increase in the oxygen extraction. But which organs are not capable of increased oxygen extraction? Why they are not able to do that?
Brain and heart.
Brain and heart. Okay, organs which already have a extraction like brain and heart are unable to compensate using this mechanism. So only these organs like kidney, skeletal muscle, and skin can improve or increase their extraction. How does anemia cause increase in cardiac output? How is it redistributed? Now the compensatory mechanisms in the cardiovascular system is increase in cardiac output to supply more oxygen to the tissues because the oxygen carried is very low.
Increasing the heart rate, cardiac output increases.
So anemia causes decrease in viscosity, which reduces systemic vascular resistance and increases cardiac output. Sympathetic activation due to stimulation of chemoreceptor by hypoxemia also contributes. That is what causing the tachycardia and increased tachycardia. So basic thing is decrease in viscosity of the blood and also fall in the systemic vascular resistance. Both of them cause an increase in the cardiac output. And this redistributed organs with higher oxygen demand like brain and heart compared to the other organs which can by themselves increase the oxygen extraction. So it is mainly to safeguard the brain and heart, the cardiac output will be redistributed to that. How does shift of ODC curve to the right help in anemia?
So it releases more oxygen to the tissues.
So causes right shift due to increase in 2,3-DPG, glucose and hydrogen ions. Okay? That is how the ODC curve gets shifted. That reduces the affinity of hemoglobin for oxygen, favoring release to the tissues at higher partial pressures. What happens if primary adaptations in blood fail, like increase extraction, ODC curve shift, capillary flow rate increase? All these things fail. These are primary adaptations. What will happen?
So increased erythropoietin synthesis from the kidney.
So these adaptations are insufficient, then there is a decrease in oxygen tension, which triggers a cascade of intracellular adaptations like hypoxia-inducible factor. Okay, this factor will be released, which results in transcription of hypoxic response genes such as erythropoietin, vascular endothelial growth factor, and that favor a metabolic switch towards anaerobic utilization of glucose. So this is a very, very important point that we have to remember, that the hypoxia inducible factor, the one which is stimulated, which will cause transcription of hypoxia response genes. So through this only erythropoietin production is increased, vascular endothelial growth factors are increased, and it favors a metabolic switch from aerobic to anaerobic utilization of glucose. So three things happen because of the release of hypoxic inducible factor. How to start the assessment of anemic patient? Now, this patient has got only 6 grams hemoglobin. So how will you start the investigative process or assessment process? She is in a severe anemia as per the ICMR classification. So where will you start? You have to find out what type of anemia is it. Isn't it?
Yes, sir.
So how will you do that first?
First, we have to
So
admit the
the
patient.
clinical,
First to assess the bone marrow response to anemia by measuring the reticulocyte count in the peripheral sphere. That is the first and foremost thing. What is a reticulocyte?
so precursors of red blood
It
cells.
is a basic precursor of the RBC. Okay, so more reticulocyte will be released to somehow make sure that some volume or some RBC, whatever we should keep it. So that indicates that bone marrow is trying to respond to the anemia. So a low reticulocyte indicates poor bone marrow response. So what are the hemoglobin independent effects of iron? Normally, iron is the main component of hemoglobin. Apart from the as a component of hemoglobin, what other functions does iron have?
So it is a acute phase reactant.
So iron is essential for many other physiological processes such as cell growth, differentiation, neurotransmission, host defense, and cardiopulmonary function. Okay. Many cellular proteins require iron to function. For example, components of mitochondrial electron transport chain proteins, enzymes involved in DNA metabolism like ribonucleic acid reductase, DNA trimase, and DNA helicase all bind to iron. And ATPase, ABCE1 needed for messenger RNA translation also bind iron. And iron plays a critical role in oxygen sensing as a part of hypoxia inducible factor pathway. So there are so many functions of iron which we have to be aware of. And lastly, the degradation of hypoxia inducible factors, especially by prolyl hydroxylases, is dependent both on iron and oxygen. And in healthy volunteers, they have demonstrated that iron depletion augments the pulmonary hypertensive response to hypoxia, leading to loading of iron loading attenuates this response that decreases the pulmonary hypertensive response. And iron is essential for immunity. And iron deficiency and iron overload increase the risk of infection. And low hemoglobin impairs the adaptive immune response, T and B cells, and infection and vaccination. What are the specific tests for iron deficit anemia?
Total iron binding capacity, sir. See,
Complete blood count to look for mean corpuscular volume and peripheral smear, serum ferritin.
Ferritin, always start with serum ferritin, transferrin saturation, PSAT, reticulocyte hemoglobin content, C-reactive protein, hepcidin level, total iron binding capacity. So these are the 6 tests which are very specific to detect iron deficit anemia. Serum ferritin, PSAT, reticulocyte hemoglobin content, C-reactive protein, hepcidin, and total iron binding capacity. What are the effects of anemia on the mother, pregnant mother?
So symptom-wise, dyspnea, fatigability,
Already there is a
palpitation.
physiological anemia, isn't it? All even
Yes, sir.
normal healthy mothers, they suffer from what is called physiological anemia. What is the physiological anemia of pregnancy?
the plasma volume exceeds the more red blood cell.
There is a disparity between increase in plasma volume and the increase in RBC. So plasma volume increases, multifold or four times more than the RBC. So the relatively it looks like there is a anemia, which is called the physiological anemia. So on the if the mother is really suffer from anemia, antenatal period, it can lead to preeclampsia, recurrent infections, cardiac failure, or preterm labor. Okay? These are the problems that can happen in antenatal period. During labor, if anemia has not been corrected from the causes of postpartum hemorrhage, congestive cardiac failure, and shock that can happen. During postpartum, puerperal sepsis, subinvolution of uterus, DVT, pulmonary embolism, failure of lactation. So many complications can happen because of anemia on the body. What are the effects of anemia on the fetus?
Intrauterine growth restriction, preterm delivery.
Transfer of iron is unaffected, but IUGR, growth relaxation, prematurity, low birth weight, stillbirth, congenital malformations, increased neonatal death, anemia after birth due to poor stores of iron. All these complications can happen. What is the iron requirement in pregnancy?
60 to 100 milligram of elemental iron.
Very good. So, patient requires initially early pregnancy 2.5 milligram per day, and 20 to 32 weeks 5.5 milligram, 32 to 40 weeks 6.8 milligram. So totally 800 to 1000 milligram during the so RBCs, out of which there is a total of this much of iron in the body. RBCs have 500, fetus plus placenta are 450, and there is a storage, third storage blood loss 200. So totally they have a requirement of up to 1150. How iron is absorbed and transported in the body? This is one of the important physiology you have to know about iron transport.
Absorbed in the second
It's
part of the
absorbed in
duodenum.
ferrous form or ferric form?
Ferrous
Ferric is
Ferrous
an
form.
ionized form. It cannot cross. Okay, just like your local anesthetic. So lumen of the gut, you have iron mostly taken by the food, and the hydrochloric acid they converts the ferric form into ferrous form. So ascorbic acid and cysteine also will help. So if it is 3 plus, it is called ferric. If it is 2 plus, it is called ferrous. So in the ferrous form, it will be absorbed first into the mucosal cells of the GIT. It will not directly go into the blood. So it will be absorbed into the mucosal cells of the gastrointestinal tract, and from ferrous form, it will be converted to ferric form to combine with what is called apoferritin. So apoferritin, apoferritin and ferric ion will become ferritin. That is the ferritin form. And this ferritin again will be reduced to ferrous form to get transferred from the mucosal cell into the plasma. And again from ferrous form, it will be converted to ferric form to again combine with apotransferase. Become what is called transferrin ion. And once it becomes transferrin ion, it can go into the tissues like liver and bone marrow and get used there. So this is how the whole process of iron absorption takes place. So remember, in these two stages, it is the ferrous form which gets transferred from the lumen to the cell and from cell to the plasma. But in between, it gets converted to the ferric form to combine with other proteins like apoferritin and apotransferrin. And then only it can be combined with that form. Once it joins with apotransferrin, even in the ferric form, it goes to the tissues. Because this protein is able to carry this ferric form into the particular cells. So that is the things that may be asked in the exam. So what are the forms of therapy in anemia?
Oral therapy,
oral
and
parenteral
IV
and
parenteral therapy.
Blood
so
transfusion.
models are oral, parenteral, which can be injectable intramuscular or intravenous, and blood transfusion to correct the anemia. These are the three modalities of treatment. Iron therapy, what are the routes and dosage?
So oral therapy, elemental iron of
60 milligram.
60 milligrams.
60 milligram per day.
Milligram per day. Ideal dose can be given as ferrous gluconate, ferrous fumarate, or ferritinate, ferrous sulfate, etc. And intramuscular iron can give first 0.5 ml test dose, then 75 to 100 milligram per day is given daily on or alternate days, given by what is called the Z technique to prevent skin staining. Any idea about how this? What is this Z technique? Intramuscular injection.
Yes, so we have to pinch the skin and the skin and the
skin and then inject it, and then after depositing you have to leave the skin. Without doing that, it will develop. The drug will have a straight passage of the needle through which it will seep out and stain the skin. Okay, so you make the path zigzag by stretching the skin and then injecting and releasing the skin. And the intravenous route, it's usually total dose is 50 interferon. It's a drug which is given. It is diluted in normal saline and it is given intravenously. The complications are local thrombophlebitis and systemic malaise, fever, etc. And indications for blood transfusion in pregnancy.
Less than 6.
Less
If it
than
is
4
failure,
milligram per deciliter in any trimester
less
of
than 6
pregnancy.
milligram.
As much as possible, try to avoid transfusion. Try to treat it by iron only. Severe anemia first seen after 36 weeks of pregnancy is one indication. Anemia due to acute blood loss like antepartum hemorrhage or postpartum hemorrhage. Associated infection, patient not responding to oral or parenteral therapy. Anemic and symptomatic pregnant woman with dyspnea with heart failure irrespective of gestational age. Okay, these are the indications or need for transfusion. How to manage normal labor in an anemic mother?
So we have to avoid pain by giving labor analgesia during first stage of labor. We have to cut short the second stage of labor.
Okay.
We have to avoid blood loss, minimize blood loss.
Okay. Anemic mother means her hemoglobin has not yet been corrected, or there is no
Optimize
time.
the anemia. Optimize the if hemoglobin is very less.
Okay. First stage, comfortable position. That is the first stage of labor. Patient must be placed in a comfortable position, adequate pain relief, oxygen supplementation should be started. And if the patient is in failure, you have to start digitalis and antibiotic prophylaxis should be given. During second stage, cut short by assisted delivery. Third stage, manage actively with same supportive therapy. And the puerperium, adequate rest, iron and folic acid for 3 months, treat any infection aggressively. Anesthetic management of anemic pregnant mother.
So
it requires a cesarean section. What is the anesthetic management? This is the management of normal labor. Suppose she requires an operative delivery.
So regional technique, single shot spinal spinal.
So avoid
After optimizing
hypoxia, adequate pre-oxygenation, oxygen supplementation in pre and post out, clear airway, spontaneous breathing technique for short procedures, avoid increase in oxygen demand like fever, shivering, or sudden hemorrhage, avoid nitrous oxide in B12 and iron folate cases. Minimum decrease in cardiac output due to induction drugs or anaerobic compression or high level of neuroxyl block. Avoid shifting ODC curve to left. Avoid hyperventilation, it causes acute respiratory alkalosis if you are doing GA. Maintain normocapnia, maintain normothermia by warming IV fluids and proper covering of patient. Intense monitoring for adequate perfusion and oxygenation by using routine monitors like SpO2, NAVP, PPCO2, etc. And central neuroxyl can be used in following adaptations. Low volume LA drugs with adjuvants to prevent high levels and sudden hypotension, or you can go for titrated epidural with catheter or combined spinal epidural. Treatment of hypertension with vasopressors like phenylephrine instead of fluids, and avoid spinal in severe B12 deficiency cases, which is likely to have subductive degeneration of spinal cord. Okay? So these are some of the things that in anemia commonly asked, which I thought students may not be very much aware, because seeing a patient with such severe anemia is very rare. But examiners pick up cases like that to give you trouble by asking all these questions. So 24-year-old male diagnosed with ESRD, stage 5, on twice weekly hemodialysis, posted for renal transplant.
Yes,
Analyze the case.
yes, chronic kidney disease with stage 5 end-stage renal disease. He's on hemodialysis, so he can have electrolyte.
So the problem is that this is on already maintenance renal replacement therapy is being given. He requires a transplant anesthesia. Okay, that much of the problem. So, what are the important history you have to elicit in this patient?
So duration of CKD. Whether he has any native, urine output or nil native urine output. When was his last hemodialysis?
How much fluid they take?
Whether it is heparinized, unheparinized.
And pre-op weight of the patient?
Regular twice weekly hemodialysis, they want to heparin free dialysis will not be done. That is only for emergency purpose. Okay? So history taking cause of CKD. How dialysis was started, whether as emergency or elective, gradually fulfilling situation. It is done as an elective after creating an AV fistula, waiting for that to mature all that. Whereas a patient diagnosed with who has never been had any symptoms, suddenly landing with CKD, they may have fluid overload and they may require an IJV cannulation, starting with dialysis and emergency. This history is very, very important. And initial problems during dialysis, like hemodynamic instability or hyponatremia, weight gain between dialysis, fluid intake restriction, quantity of native urine, any fluid overload features, what are the drugs he is taking. And transplant plan, there is a live donor or a deceased donor transplant. Okay? All this history is important. So what pre-op evaluation, investigation and instruction you have to give this patient?
So we have to check the vitals, whether he has associated hypertension or.
Very good. Just like CVS,
whether he has any, in which hand he has AV fistula and it is working or not, so.
Working is undergoing phase with you without working away. So pre-op evaluation, general examination, systemic examination of CVS, RS and fluid status. Some patients, despite having a twice weekly hemodialysis, still may have some pedal edema or facial edema and all those things. So fluid status assessment is very important. GIT, any GERD or reflex present, and acidosis, autonomic neuropathy features, musculoskeletal pain or other weakness, electrolyte balance, BP control, effectiveness of hemodialysis in controlling the fluid status and reducing the urea and creatinine. All these things are the pre-op evaluation we have to do. Pre-op investigation, all repeat plus blood grouping, tissue matching for transplant. And pre-op instructions, NPO, pre-medication, drugs to be continued, timing of hemodialysis, and immunosuppression of what drug they are going to use, at what time they are going to use. Intraoperative anesthetic management, difference between live donor and deceased donor. I'm not taking this in a very detailed manner because I think you had a question in your theory exam on this, and also this is a very frequently case nowadays, so all of you are quite aware of all the details, and many of you have had a chance to do a transplant also because many of you are performing this. I thought I will just keep questions to the minimum this session. So intraoperative, how do you give anesthesia for the, what is the difference
Live
between
donor
live
is
donor and deceased donor?
live donor is selective, sir. Deceased donor is emergency procedure, sir. So we
Semi quasi emergency, not full emergency. Deceased donor, you do not know when the kidney will arrive, but they will give a precaution that somebody has agreed to donate and kidney may arrive in about 8 hours or 12 hours. So this is a quasi-emergency, whereas live donor transplantation is a elective procedure, but you require a twin OT interconnected for live donor because you have to start both the donor surgery and recipient, and there should be a door connecting the two theaters to bring the harvested kidney to the recipient side. Okay? So intraoperative live donor is elective surgery done in twin OT setup, two team of doctors. Whereas deceased donor is semi-emergent, PA for both donor and recipient in live donor transplantation. And this donor surgery may be done by open method, lap or robotic nowadays for donor and open for recipient. And usually IV induction, RSI, etc. if potassium is normal, and atracurium or citratracurium is a drug of choice. All the fentanyl and other things that you are given are usually maintained with fentanyl of the air, volatile XTO ISO, reversed at the end and extubated. Normally, you don't require any elective ventilation unless some severe acid-base imbalance and the patient not recovering from the effects of muscle action, then you have to extubate. Otherwise, most of the recipients are extubated on the table. Okay? A 65-year-old male swelling a dry jaw in 4 months, which disappears on lying down and appears on standing and talking. He is a known hypertensive for 10 years on telmisartan 40 milligram OD. So this is a hypertension complicating a patient with a groin hernia. So analyze this case.
Geriatric. Patient is elderly, so geriatric concern is a known hypertension.
Okay. Second problem is chronic hypertension, 10 years of hypertension. Okay. So groin swelling appears on coughing, probably reducible hernia. Comorbidity is hypertension, 10 years on angiotensin receptor blocker drug. So what important points in history to be elicited? It's a simple hypertensive patient.
So when was he diagnosed and what drugs he is on, whether it is controlled?
First of all, how the hypertension was detected. Always that is a very important history.
to master checkup or any
Age-related changes, serious renal, thing about how to evaluate the hypertension. So also how it was detected by routine checkup or by symptoms like headache, giddiness, or palpitation. Treatment history, same drug for 10 years or change of drug. need for escalation or reduction in dosage? How is the follow-up? Regular checkup with physician or home monitor? Any target organ dysfunction? So what are all the target organs that can be affected by chronic hypertension?
Kidney, brain, and eyes, sir.
Yeah.
Heart.
Yeah. So 3 organs: kidneys, heart, and eye. And very rarely, very severe uncontrolled brain also you can get a cerebral hemorrhage or a stroke. Okay? So apart from that, commonly spread hypertensive retinopathy, hypertensive coronary artery disease, hypertensive renal disease. These are the 3 things. So target organ dysfunction also to be assessed. And what are the points in physical examination? Examination of general airway, back and spine, routine as for any other case. Okay, system-wise examination for RS, RS, etc. And pre-op investigations, instructions, and pre-medication.
Routine plus
Routine
CVS.
surgical plus serious investigations. Okay, like ECG, echo, etc. Drug dosage adjustment. Withholding AC, ARB. It is also another pre-op investigation. NPO advice. Pre-medication, antacid prophylaxis, anxiolytic. And what is the plan of anesthesia?
Sir, if it is open, based on the surgeon, central neuroaxial blockade.
Central neuroaxial blockade. So the plan preferred will be central neuroaxial, single shot, combined spinal, epidural, or hernia block also is one of the options. The hernia is small, with the content which is simple momentum, then it is easy to do it in the hernia block also. RGA, due to patient refusal, avoid alpine anesthesia. What is this alpine anesthesia?
We have to avoid overshoot BP and also BP fall during.
So too much of hypertension or hypotension intraoperatively should be avoided. It's called alpine anesthesia. Post-op management.
Continue anti-hypertension drug. Monitor vital.
Adequate analgesia.
Between oral intake, watch for voiding of the spinal, return of motor power and ability to ambulate, post-op nausea and vomiting prophylaxis, resumption of antihypertensive drugs. So these are the common things. Is this case suited for daycare?
Yes, sir.
Yes, it's the majority we have done as daycare. The criteria for selection for daycare, anesthetic modifications for daycare surgery, all these questions can be asked. So, can you just tell me 1 or 2 points about what modifications you will do if it is planned as a daycare procedure?
We will use central neuroaxial block.
We can do it under LMA.
Or
we can do it
LMA.
LMA.
Or only block.
Or only block. Okay. So that is the management that is. And discharge criteria for daycare, you should know all this. Potentially can be asked. Now, next case scenario is 45-year-old female with complaints of swelling in front of neck, progressively increasing in size, causing difficulty in breathing while lying supine and difficulty in swallowing. How to proceed? Analyze the case. What is this case probably?
Thyroid swelling.
Thyroid swelling. Okay, so 45-year-old female, progressively increasing, likely to be a thyroid mass. Okay, but she is also having difficulty in breathing while lying supine and difficulty in swallowing. What does it indicate?
Retrosternal goiter.
Chronic thyroid, chronic mass also retrosternal extension
The mass
of
is
thyroid.
very huge or it is malignant. Okay? Need to confirm the diagnostic examination like movement of the mass during deglutition. If found to be thyroid mass, find out the functional status. whether it is euthyroid, hyper or hypothyroid, then this patient has pressure symptoms in terms of malignancy also in infiltration. These are the points that you have to first make sure. What is the history you want to elicit?
So when did she notice the swelling? Whether it is
What is the rate of growth?
rate of growth associated with
onset
pain?
Any sudden rapid increase in size, any features of hyper or hypoactivity, any change in voice or noisy breathing, any pain in the swelling, any other comorbidity, any treatment other than allopathic treatment has been given. This history to be elicited. What are the important points you have to look for in the examination? What are the methods of examining a thyroid swelling? Do you know the names?
Priscilla's method,
Prile's method, Lahey's method, and Priscilla's method.
The methods of examination can be Lahey, Prile, Priscilla. And to rule out retrosternal extension, you have to do what is called Pemberton sign. And what is Kocher's sign?
carotid infiltration by
Carotid infiltration is very sign.
On giving pressure over the front of neck, there will be strider.
Strider. Okay. That is the Kocher's sign. Okay. Very sign is only for a carotid action. Not able to feel the carotid by the mass and encircling them. Okay. Then eye signs, if the patient has hyperthyroid, you have to know all the names and what all the things that happen. And what information can be obtained from examination of the hands of the patient with thyroid swelling?
Patient can have acropathy, palpitation, tremors, tachycardia.
So a lot of things can be assessed. Can be sweaty, warm, or dry and cold. Sweaty and warm in which condition?
Hyperthyroid.
Hyperthyroidism. Dry and cold in hypo, clubbing in thyroid and hypothyroid. Ankylosis in hypo or hyper. Palmar erythema, pallor of the palm trees, tremor, muscle wasting, puffy palm or heart palpitation. All these things can be happening in examination. Always it is a hypothyroid patient look for carpal tunnel syndrome. Why pulse examination is important in this patient?
The hyperthyroid patient will have tachycardia
and arrhythmias also can happen.
Arrhythmias also come.
If it is hypo, it can have brady. Why huge thyroid swellings are likely to cause difficult airway management? As it is, if the thyroid gland is very huge, you always consider that patient as a difficult airway patient. What are the reasons for that?
So they'll compress the trachea.
One is compression of the trachea, very good. Then,
Sir, anatomical
palsy.
Vocal,
They'll cause vocal cord, recurrent laryngeal nerve palsy.
That will be seen as a strider or hoarseness, all that. But in intubation, as a management for intubation, what are the difficulties? One is compression, you may not be able to pass the tube. Okay. Then, if it is unilateral swelling, what can it do to the trachea?
Tracheal deviation.
Deviation. It will again not allow you to pass the tube correctly. If it is a huge swelling up to the chin, will it allow you to open the mouth and increase your laryngoscope easily?
No, sir.
No. So like that, AP compression, difficult introduction of scope, lateral deviation, and if you try to use the LMA position may be not well suited, and in an emergency, doing a front of neck access will be impossible. So these are all the reasons why any huge thyroid swelling is considered as a difficult airway case. What are the investigations to be done in a thyroid patient?
Along with routine investigation, ultrasound neck, X-ray neck, AP lateral.
thyroid function test.
Thyroid function test. CBC, thyroid function test, X-ray neck, X-ray chest, tubes, ultrasound of the gland, FNAC, and serum calcium. Very, very important. Why serum calcium?
It can be
So
occur hypocalcemia.
to rule out hypocalcemia.
Okay. And to evaluate the thyroid function results, how do you evaluate the thyroid function results? Whether it is hyper or hypo, what are the values that you look at for to decide whether
So if the TSH is high and T3, T4 is low, then it is hypothyroid, sir.
always primary or secondary to say, okay? This will
Yes,
tell
sir.
you low T3, normal T3, high. So low TSH compared with T3 and T4 is always we need to find out. If low TSH and low T4, secondary hypothyroidism. Whereas if it is normal T3, subclinical. If it is high T3, it is primary. Like normal TSH with low T3. Here you find there is one entity called severe NTI. What is this NTI? Here also it is given NTI. So 3-4 conditions you can diagnose. One is primary hyper or hypo. Second is secondary hyper or hypo. Third is subclinical condition, and fourth is NTI.
Non-thyroid.
Non-thyroid illness, correct, good. So NTI, it is called non-thyroid illness syndrome, a condition that causes changes in thyroid hormone levels in people who are acutely chronically ill. So they don't have a primary per se thyroid problem, but the T3, T4 values and TSH values are altered in them. So that is called, this is also called the sick euthyroid syndrome. Okay, this is another name for that, is the sick euthyroid syndrome. What are the causes for this?
Infection and
Can be nutrition, cytokines, glucocorticoids, starvation, infection, trauma. And all these things can cause this particular problem. What is the choice of anesthesia for thyroid surgery?
general anesthesia with
endotracheal.
Endotracheal intubation.
and block.
Prefer GA with a systematic or nasal radius introduced orally. Position of the patient is supine with neck extension. Eye protection is important. IV line placement is important for easy access. Monitor location ideally at the foot end of the table. Pressure point to be protected. Controlled versus spontaneous respiration. Some people still do the spontaneous respiration also. When will you resort to spontaneous respiration nowadays? What is the indication?
If the patient has retrosternal extension.
So, you have to get it into control because the surgeon may open the sternum or do it with a mediastinoplasty and all those things. When you want to assess the vocal cord function intraoperatively, if you want to stimulate the recurrent laryngeal, the surgeon says that, then better to preserve spontaneous ventilation. Okay, so that is just like your neuromonitoring where you avoid muscle relaxants. Here can give inhalation agents that will not cause any problem, but being a motor nerve can be easily stimulated if the muscle tone is preserved by spontaneous effort. What are the regional techniques for thyroid surgery?
Superficial cervical plexus block. And
cervical epidural anesthesia.
Superficial plus deep cervical plexus block for unilateral surgery only. We should not give it for bilateral surgery. Cervical epidural for bilateral surgery. What are the likely intra-op complications during thyroid surgery?
hemorrhage, hypocalcemia, vocal cord palsy.
Intraoperative complications.
So tube endobronchial displacement or tube dislodge.
Endobronchial will it go when you do the extension?
No, sir.
Tube usually migrates out, not inside.
Migrates.
Okay? Only flexion
Yes,
it will become endobronchial. Extension it will try to slip out. Okay? So
Yes,
because
sir.
the length is extended, it will always try to slip out. So proper position. Thyroid crisis, hemorrhage, hair embolism, rarely need for sternotomy for retrosternal daughter. And the newer challenges nowadays is intraoperative neuromonitoring of retrolaryngeal nerve, endoscopic thyroidectomy, transoral robotic thyroidectomy. Okay, these are all the new challenges we have. What are the likely cause of airway complications?
Sir, recurrent laryngeal nerve palsy because of compression and hematoma.
So it can be
Airway
classified
compression.
immediate, intermediate, and late. Okay, immediate recurrent laryngeal injury due to surgery,
Malaysia.
Malaysia, injury. Intermediate because of hematoma. Late complication because of hypertension. So these are all the common things that happen in the thyroid case. Now there is a this is TRP, which is normally given as a times as a short case, but sometimes it is a long case also. So we have a male patient who is 20 years duration, 15 years diabetes, hypertension 20 years, 15 years diabetes, it's a progressive difficulty in voiding, diagnosed with PhD, posted for TRP. So in the analysis, what are the problems?
Sir, elderly patient, geriatric concerns,
So
chronic hypertension, diabetes.
Geriatric, hypertension, long-standing, diabetes, long-standing, PhD with voiding difficulty. The 4 problems. What are the important history?
Sir, history regarding systemic cardiovascular respiratory
Always
insufficiency,
geriatric versus biological age assessment. Okay?
age-related
Various system activity, effort tolerance, cognition, is comorbidity controlled or uncontrolled. Okay? So information regarding primary problem of voiding. What are all the symptoms that will happen if a patient has enlarged prostate with regard to voiding or urination? This mnemonic, this fun.
hesitation, infrequent, intermittent,
Steam is very thin, frequency
thin
is
stream.
increased, urgency is increased, and nocturnal urination. Okay? That is the mnemonic for hesitancy, intermittency, thin stream, frequency, urgency, nocturia. These are all the things. Any other associated surgical conditions due to straining like a hernia or hemorrhoids also to be taken into history. Any medical treatment tried before are being continued because many of them are initially put on drugs for DHT. What are the drug treatment advice for DHT?
Sir, prazosin alpha.
Classify the drugs. What alpha blockers?
High alpha reductase.
High alpha reductase inhibitors. Okay? So these are the 2 categories of drugs that are being used. Gland size and lobe involved. That is discussed in the examination. And pre-op evaluation, specifically to the comorbidities, hypertension controlled or uncontrolled, drug treatment, target treatment. Again, DM controlled or uncontrolled, drug therapy, and target treatment. Musculoskeletal is very important because we are going to put lithotomy, joint mobility of hip and knee, back and spine examination is very important. And renal involvement due to obstruction and back pressure effect along the and serious history of coronary artery disease, arrhythmia, valvular heart disease, RS for effort travel. These are all the things that we have to remember. And pre-op investigation is based on any particular test. apart from the routine investigation, should you insist on any particular examination in the exam? To identify TARP syndrome, that is the clue. What will happen in TARP syndrome to electrolytes?
Serum sodium.
Sodium.
That is very important. So routine test for surgery plus serum sodium. So preoperative sodium level should be always maintained. And how is the risk stratification done in this particular case? So based on chronological versus physiological age, severity of comorbidities. Pre-optimization and instruction.
Sir, NPO to withhold oral hypoglycemic drugs and insulin on the day of surgery, to withhold ARB and ACE, and to continue other antihypertensives.
So BP control, glycemic control, drug adjustment. If UPO is present.
Yes, sir.
NPO, drug adjustment, anti-anxiety, anti-anxiety, sugar management. Intraoperative management, advantages and disadvantages between regional and regional.
Sir, in a regional, patient will be awake so that we can easily assess the patient if he develops TURP syndrome or patient having bladder perforation. So,
Disadvantages of RA.
Top to it.
Sudden hypotension can be intraoperative preferred technique is single shot tuberculous block. The reason is it is technically easy. You can, as you said, identification of TURP syndrome or bladder perforation is more easier. So mild hypertension also helps the surgeon to have a clear vision, early diagnosis of TURP syndrome. Disadvantages: prone for sudden hypotension, shivering, and penile erection. These are the three important side effects of it. And intraoperative fluid management, assessment of blood loss, and assessment of fluid absorption. All these questions can be asked in the examination, and I hope all of you know how to calculate the blood loss or the fluid absorption. The formulas we have discussed in the classes, and all about irrigation fluids. And what is the preferred irrigation fluid? Normally
0.9% NS.
NS. But many institutions use 1.5% glycine. Okay? Maybe NEOT you are using
NS, sir.
NS.
other institutions, as far as I know, 1.5%. And so questions that can be asked on that. And patient with pacemaker, also you have to be prepared to find out that may be the one that can be added as a comorbidity. And TURP syndrome, all the features, how to identify. So clinical features, complication, diagnosis, information, and treatment. You should not make any mistakes. And if G is required due to patient refusal, spinal or coagulopathy infection, how to identify TURP syndrome, another common question. So how do you identify TURP syndrome in a patient under GA?
Based on the monitors, patient can have hypertension and tachycardia, then followed by bradycardia. Patient can have arrhythmia.
So mainly serious changes only. Okay, so that is how you identify. But rule out any pain-related hypertension, all that before you diagnose TURP syndrome. Of course, this affects the challenge. So in any case, any doubt, what should you do?
Ask the surgeon to stop.
No, that is the treatment. But before that, if you want to confirm whether it is TURP syndrome or not, what should you do?
We have to
Where
send
the
the
serum
blood
sodium comes into play. Okay, you can send an electrolyte sample, and if serum sodium is normal, it is not TURP syndrome. Serum sodium oxygen is low, hyponatremia has happened, it is definitely okay. That is the easiest method. And post-op problems and management. What are the common post-op problems after TRT?
Patient will be on continuous irrigation even post-op, sir. So we have to look for serum sodium post-op.
Okay. More than that, they have done a surgery. It is
Clot retention.
clot bleeding and clot retention. And so post-op pain management. Because why the pain is there in TRT cases? Is the prostate very sensitive? Where does the pain arise after TRT surgery? This is the location causing the pain.
L1.
Bladder.
I'm not asking the root value of the pain. I'm asking the anatomical site from where pain is achieved. How do they arrest the bleeding after TRT surgery? What do they do to the Foley catheter? How much water they put in the Foley bulb? You not watch the surgeon doing? Is it like just 10 or 15 ml that you do for a regular Foley catheter for urinary drainage?
They'll put increased volume and
They
stretch
put
the
a
Foley's
40
catheters.
ml. Okay, they put a 40 ml of fluid, and what do they do to that Foley catheter? They just inflate with 40 ml and leave it, or pull it and fix it to the thigh.
They'll stretch and
They stretch and strap it to the thigh. Okay, so that Foley bulb only compresses the bladder area called the trigone, and that trigone is a very sensitive portion. That only causes the spasm and the pain. Okay? That is the mechanism of pain after pain. It is not because of the resection of the prostate gland. It is the compression by the Foley bulb on the trigonal area which causes the pain in the spasm, sometimes happen in bladder spasm. During bleeding, clot resection, it may need exploration. Supposing the exams have asked you, the patient has undergone TRT in the morning, 8 o'clock. At 12 o'clock, the surgeon goes and looks at the irrigation. It is full of blood. So he wants to re-explore. What anesthesia you will give for re-exploration? Stop bleeding. Can you repeat the spinal?
Patient hemodynamically stable.
First answer should always be how to assess the hemodynamic stability of the patient. Patient has because it is very difficult to find out the amount of bleeding in the presence of continuous irrigation. The patient could have lost quite amount of blood. So assess the hemodynamic stability. If the patient is hemodynamically stable and you have adequate blood to replace, if there is a further loss, you can always go for a repeat spinal, no harm. But use a smaller size needle, use a lower volume. Whereas on the contrary, if the patient is having a hypotension and tachycardia because of the acute bleeding, then it's always preferable to go for general anesthesia. Because sometimes the exploration may stop with decauterization, or sometimes it may go on to expose the internal iliac artery ligation. All those things can be attempted. Okay, so it is better to go for DA. And the TERT patient with pacemaker, you have to first take pacemaker introgression. Program, what is the indication for that? What is the dependency? What is the intensity? So all those things that we have discussed earlier. So keep reviewing that and keep this question also in there. The next question is 45 years old, employed in a cement factory with a hysteroscopy suit of 4 years duration. Sputum is more while lying on his left side and less in supine or right side. One episode of coughing out of blood. His wife says he has a foul smell in his breath. He has coarse leathery rolls spread over right thorax. clubbing of the fingers and toes. How do you manage? What is the diagnosis?
Bronchiectasis, sir.
Bronchiectasis. One of the rare cases, certainly repeated, is the reason why I do this. To analyze the case. So this cement factory worker, what occupational hazard we can develop?
Asbestos.
Asbestosis. Cement factory is cytosilicosis actually.
Silico.
So
Yes, sir.
because silica is being used in cement factory, so it is cytosilicosis. Clinical exam findings, they all indicative of chronic bronchiectasis. One episode of coughing indicates pneumocystis, which is also in favor of chronic bronchiectasis. What are the history you want to elicit in this patient?
S- So whether he has fever to rule out acute active infection.
They can have recurrent pneumonia.
Fever, loss of weight.
Apart from total quantity of sputum is bringing out
Yes.
per day, color, consistency, and odor. History of smoking, weight loss, appetite loss, recurrent fever. What simple examination of the sputum can help to confirm the diagnosis?
Culture sensitive. Examination.
Identify
Color of the sputum. Early morning.
3-layer sputum. Have you all heard about that?
No.
So 24-hour collection of sputum in a conical glass jar will exhibit what is called 3-layer sputum, which is pathognomonic of this particular collection. So this is how the jar will be. So it will have an upper frothy layer, middle thick or liquid layer, lower sediment layer which where the epithelial cells and debris are collected. Okay? So this is the classical 3-layer, upper frothy, middle liquid, bottom solids. So this is the sedimentation that will happen. Olden days, we used to get a lot of bronchiectasis cases, and all the patients will have a jar like this by the side. They will be instructed to stick all the sputum only into that and cover with the lid. Next day morning, when you go and see, you will see this classic appearance. What are the types, causes, their examples for bronchiectasis? What are the 3 steps in which bronchiectasis can happen in the lung?
Saccular.
So cylindrical,
Saccular
fusiform, and saccular. Okay, fusiform, saccular, and cylindrical are the 3 types based on the shape. Causes are, it can be congenital or acquired. You tell me what are all the congenital causes?
Cystic fibrosis.
Cystic fibrosis is one, very good.
Cartaginer syndrome.
Cartaginer syndrome, which is one feature of that is bronchiectasis. So congenital can be severely dysfunction, which includes Cartaginer syndrome also.
Yes.
Hypogammaglobulinemia, cystic fibrosis, connective tissue disorders, or inflammatory bowel disease, Marfan syndrome, or yellow nail syndrome. These are all the congenital causes. Acquired causes?
Smoking and infections.
Smoking and infection. Lead to? There are a lot pneumonia due to whooping cough, measles, pulmonary tuberculosis. Inhaled foreign body in childhood or altered conscious state due to stroke, alcohol intoxication, or GA for dental extraction, tonsillectomy, or mere drowning. And bronchial obstruction due to tumors or nodes in tuberculosis. ABT complicating asthma, resistant to bronchodilators, and high dose of steroids. Immunodeficiency states like HIV, chronic lymphoid leukemia, and nephrotic syndrome. Toxic insults like aspiration or inhalation of toxic gases and chemicals. So these are all the acquired causes for bronchiectasis. So The main reason for this is when you take the history, you have to ask for all these possibilities, whether they had any dental extraction under GA, whether he is a chronic alcoholic, whether he has had any stroke, whether he had a tonsillectomy, whether he had a drowning. All these questions will lead to identify whether it's an acquired bronchitis. What is the pathophysiology?
So chronic infection and inflammation leading to progressive destruction of bronchial wall,
And
decrease in the thickness of bronchus and increase in the mucosal thickening.
That's very good. Okay. Inflammation and destructive changes in the walls of the medium-sized bronchi at the level of segmental or subsegmental level, and bronchial and peribronchial inflammation and fibrosis, ulceration of the bronchial wall, squamous metaplasia, mucus gland hyperplasia, bronchial neovascularization. New vessel formation happens with hypertrophy and tortuosity of bronchial arteries. This is the reason for these new vessels being not having a solid wall can sometimes break and cause hemoptysis. What are the complications of bronchiectasis? Apart from the respiratory problem, what other systems can be affected? The chronic infective state.
Yes, sir.
So recurrent pneumonia or pleurisy, massive hemoptysis, brain abscess, myelofibrosis leading to nephrotic syndrome, or pulmonary emphysema or pneumothorax. These are all the complications. What investigations you have to do?
So routine investigation, sputum, along with its sputum culture sensitivity and
To diagnose the condition,
Septic X-ray?
sputum culture sensitivity, CXR, may show rim shadows or tram track like line appearance, high resolution CT, PFT for reversible obstruction, bronchoscopy, saccharine test to assess nasociliary function, cystic fibrosis, genotyping in upper lobe bronchospasm. These things are the investigations. What is the treatment?
sir, antibiotics to treat active infection, chest physiotherapy, postural drainage, incentive spirometry.
Very good. That is the conservative line of treatment. So clearing
Yes, sir.
mucus secretion from the affected parts is the main goal, achieved by antibiotic therapy based on culture and sensitivity, postural drainage according to the lobe involved, bronchodilator therapy, mucolytic drugs to help loosen the secretion, proper nutritional support. What scoring system are used to assess the severity of this disease? What variables are used in them?
So ratio of bronchial wall thickness to mucosal thickness.
Where did you study that?
Pathology.
The two scores that have been used are bronchiectasis severity index and KCED, taste score. So the variables used in bronchiectasis severity index are these following: age of the patient, BMI, FEV1, hospital admission within last 2 years, number of exacerbations in 12 months, then MRC breathlessness score, and P. aerogenesis colonization, colonization with other organisms, radiological severity. So based on this, we have 0 to 4 points. It's called mild disease, 5 to 8 moderate disease, 9 and over severe disease. So the points are all given at the near the numbers itself. So this is the one system of assessing the severity: mild, moderate, and severe. The other test is an acronym for FEV1, age of the patient, colonization with P. aerogenesis, extension of radiological bronchiectasis, and dyspnea. So FACD, all these things are the first letters. FEV1, F2, AG. C for colonization, E for extension of radiological bronchiectasis, and D for dyspnea. So here The points are 0 to 2. The maximum point you will get is only about 7, because in FEV1 you have 2 grades, 0, 2. For age again you have only 2, plus 0 and 2. For colonization you have 0, 1. So maximum you can get is only 7 points. And based on that, 0, very 0 to 3 is mild, 3 to 5 is moderate, and more than 5 is severe. So that is how these two scoring systems are used. So how do you optimize this patient preoperatively? The same principle, how you treat. So you have to reduce the sputum level. First step in pre-optimization is a proper assessment of the patient, including cardiopulmonary reserve, apart from general assessment. All patients having pulmonary resection should have a preoperative assessment of, that is, if patient is posted for lung resection, either lobectomy or hysterectomy, then you have to look for the 3 areas: lung function, lung parenchymal, lung mechanics, parenchymal function, and cardiopulmonary reserve. So the most valid single test for post-thoracotomy respiratory complications is predicted post-operative FEV1. How do you calculate this? What is the formula to calculate the predicted post-operative FEV1 percentage?
So 1 minus pre-op FEV1 into number of lung segments removed divided by 44.
42.
40.
That 1 minus the preoperative FEV1 multiplied by 1 minus percentage of functional lung tissue removed by 100. Okay, so that is the way it is calculated. That is how many segments or how many percentage of lung you are going to remove. That has to be subtracted from what? Not the FEV1. So this is the formula that we use, and it is a percentage value. It is not ml or liters. So what is acceptable with post-op FEV1? What complications can happen if the value is low? What is the minimal percentage they should have? More than 40. Okay, the patient with a value of more than 30, no major proposed pulmonary complications will happen. But the majority complications occur if the value is less than 40. In all patients having a FEV1 value less than 30%, they will definitely require post-op mechanical ventilation. What are the indications for lung resection surgery, and what surgery is needed for that?
Lung reduction surgery.
Not lung
Lung,
reduction. Here,
lung volume.
volume is not expanded. Lung volume reduction surgery is for emphysema. Bronchiectasis, patients who do not show improvement with conservative management. Having severe hemoptysis recurrently or recurrent pneumonia may require surgical removal of the affected part of the lung. Okay. So it will be either a lobectomy or a pneumonectomy. Okay. So if it is single lobe involved, it will be lobectomy. If it involves the entire lung on one side, it may require a pneumonectomy. So how is patient evaluated for these surgeries, either lobectomy or pneumonectomy? It's a method of evaluation.
Three-legged.
Three-legged approach. Okay, patient needs a three-legged stool approach to assess the lung mechanics, the parenchymal function, and cardiorespiratory level. What is 3 areas of lung? The same thing has been already given. So the same thing has to be repeated. How anesthesia is administered for lung resection surgery?
Double lumen
So
tube.
general anesthesia with double lumen tube.
Lung isolation may be needed. That is the answer that you have to give, because this is an infected secretions that are there in the lung. So to prevent soiling of the normal lung, may require lung isolation, one lung ventilation. Okay? So lung isolation may be required if there is a risk of soiling of the normal lung. So common technique is one lung ventilation with a double lumen endobronchial tubes. The patients undergoing thoracotomy for lung resection are placed in lateral decubitus tube, which can produce some preventable complications. So what are all the precautions or important things that you have to take care when the patient is in this lateral position? Enumerate the care that you have to give to prevent the complication. Start with the first one. You have to do a head-to-toe survey. This answer, if you say that, the examiner will be very happy. So what are the head-to-toe survey you have to do?
We have to stabilize the head. We have to look for cervical
Different
spine.
compression of the dependent eye and pinna because it is in the lateral position. Okay. Then make sure that cervical spine is in line with thoracic spine. Just like prone position also, here also you have to make sure that cervical spine is in line with thoracic spine. Dependent arm compression should be avoided. Avoid extensive stretching of the non-dependent arm to prevent injury to suprascapular nerve. Avoid pressure on the dependent leg and injury to peroneal nerve. Don't flex the non-dependent leg too much to avoid sciatic nerve injury. Adequate padding to all bony pressure points. So these are all the common things that we have to. And what is the anesthetic management of lobectomy or hypopnectomy? How do you avoid the hypoxemia that is likely to happen with one lung ventilation? That will come later. But here, pre-op NTO guidelines, avoid sedation or narcotics in patients with compromised respiratory function. Intra-op monitors routine plus arterial line for direct TB monitoring, for ABG sampling. Pre-oxygenation, wide bore IV line in the non-dependent limb. Intravenous injection with propofol, analgesic, fentanyl, thoracic epidural sited at T9 or T10, between T9 and T10 space. Relaxant of choice is Vecronium. Placement of ventricle or double lumen tube as indicated. Maintenance with air and oxygen. Volatile with control ventilation. Fluids and blood to maintain adequate volume using warming devices. Post-op reversal and extubation based on the pre-operative FE1 value, predicted post-operative FE1 value. Now, this case techniques of preventing hypoxemia during one lung is a very commonly asked question. What are the things that you can do if you are putting a double lumen tube and patient desaturates? How to correct that?
Sir, 100% oxygen. Suctioning both
so
the.
Ensure first thing, ensure correct placement of DL tube. Okay, then increase. In case of gradual desaturation, increase FiO to 100. Then
we have to suction both the lumens separately. Apply CPAP to the operating collapsed lung. Applying PEEP to the ventilated lung.
if not improving, add 10 centimeter tube to the ventilated lung. Add CPAP to the dependent lung. If chest has been opened, ask the surgeon to clamp the pulmonary artery, supplying the lung to be removed. If desaturation continues, abandon OLV and switch to two-lung ventilation. These are all the 6 steps that you have to remember always. Ensure correct placement, then increase FiO2, add PEEP to the ventilated lung, CPAP to the dependent lung, clamp the pulmonary artery of the deceased lung. If you are still saturation not improving, abandon one lung ventilation, switch to two-lung ventilation. Post-op complications following pneumonectomy or lobectomy and how to manage them, especially pneumonectomy. To remove entire lung on one side, control the problems that can be produced. So respiratory failure, okay, you have to support ventilation, Atelectasis, you have to do a bronchoscopy and remove any obstruction and ventilation. Pneumothorax, check working status of ICD. Cardiac herniation, which is an emergency. Thorax emergency exploration. Hemorrhage, emergency reopening to arrest bleeding. Arrhythmias, check characterize ABG and the guilty as an it will be usually SVT. And bronchial disruption of some flow. This is again the emergency exploration. Right heart failure because of removal of vasculature of one lung. It will produce a strain on the other circulation, which will lead to right heart failure. So I could give you dopamine, migrenol, PG, and nitric oxide. These are the treatment for right heart failure in this case. The last question. 1-year-old male baby weighing 10 kg posted for congestive hydrocele repair. Child had cough and fever 2 weeks ago, treated by pediatrician and given clearance. So the analyze the case.
Pediatric age group. Reactive airway.
Yeah, recently infected reactive airway. Posted for a minor surgery. Okay. 1-year-old baby recently recovered from LRI. Important history. All pediatric cases, but history is very, very important. But history rules out prematurity, any neonatal issues, growth with gain, milestones, and immunization. Examination and investigation.
So, examination of airway.
Examination and other congenital anomalies. Airway to rule out residual LRI. What is post-acute auscultation?
So if we hear added sounds,
induce a cough and then auscultate the lung, it will prevent or it will exhibit any occult infection. Okay? For a normal quiet respiration, you may not find any lung signs. But once you make the child cough, how do you make the child cough? 1-year-old child?
by stimulating palpate index finger over the trachea.
At the suprasternal notch, you put your finger and then try to tickle the trachea, okay, or press the trachea. That will induce a cough. That will, after the cough subsides, if you auscultate, you will get the crackles or valves occurring. Silent infections. CXR, epidemic lung good. It's anesthetic management of choice.
Caudal LMA with caudal analgesia.
So, sedation, caudal will be ideal. So avoid GA, specifically endotracheal intubation. LMA may be used if GA is contemplated. IM ketamine with caudal. Hernia block technique and nerves involved. All questions can be asked if you say this. And the allied questions that you can anticipate is be prepared for anatomical and physiological differences between pediatric and adult systems, airway, PVS, and all that. Challenges in anesthesia due to the differences, fluid management in children. And anatomy of caudal space and technique of block, dosage of various levels using caudal block and drug use, concentration and additives. And all about daycare surgery. So these are all the things that you have to keep in your mind. So that I think fairly
Thank you, sir. Thank you very much, sir. It was
Thank you,
very
sir.
elaborate and extensive, sir. I hope the students got a little overdose today.
But I have completed that so that I thought I finish it up so that from first onwards they will be 19th and 20th. I think the dates are being given. They have hardly yeah. So I think we finish off with this. Unless they want something else in the next week, they can go for the study holidays and
Yes, sir. Thank you very much, sir. Thank you very much, students. If any
You
doubts, you
all
can.
the best and be very think calmly, get nervous, for all your questions for listening to the examiners. Take time to answer. Don't be in a hurry and say wrong answers. But then don't take too much of time also. That will also be important. So try to think and give your answers. Okay. I wish you all the success.
Thank you.
Thank you, sir.
Yeah. Wish you all the best,
Thank you,
students.
sir.
Thank you, sir. Can we sign off the meeting, sir?
Yeah, please. Thank you.
Thank you, sir. Thanks, sir. Good night, students.